Hello, everyone. Greetings of the day. I'm Dr. Monica Tandon, professor in Manaprashna Dental College, Faridabad. I will be discussing the topic of pulpal and periapical pathologies. Now, when we discuss any patient who's coming to your clinic, your department, out of 10, at least 6 patients will have some or the other pulpal or periapical pathology. So it is very important that you diagnose your disease properly so that you can provide appropriate treatment care to the patient and send back a happy, satisfied patient. So coming to pulpal pathologies, the physical causes, there are different type of causes involved which causes the diseases of the pulp. The common ones are physical causes, which include mechanical causes, trauma, which can be accidental or iatrogenic, pathologic wear of the teeth, such as attrition, abrasion, etc., cracked tooth syndrome. That means there is a faint crack. It's an incomplete crack which is passing through the tooth. Barometric changes, also known as barodontalgia or aerodontalgia. Thermal causes, when you are generating heat during cavity preparation, when you are working on a very low speed or high speed without a coolant, that can cause damage to the pulp. Exothermic heat from the setting of the cement. Conduction of heat and cold through deep fillings without a protective base. So when you consider this point that whenever you are making a cavity, the remaining dentine thickness plays a very important role in determining your pulp protection. So if you're very close to the pulp, then you need to adequately protect the pulp so that any temperature changes will not cause irreversible damage to the pulp. Frictional heat caused by polishing or restoration can also increase the temperature of the surface of the tooth and thereby cause pulpal damage. Electrical, galvan current from dissimilar metallic fillings. Chemical causes such as phosphoric acid, acrylic monomer, erosion, they all have the capacity to damage your pulp. But amongst all, it is the bacterial causes which are more or most important. That is because dental caries is one of the most common condition affecting the tooth. So it is the most prevalent disease apart from periodontal problem. And these bacteria can pass through the dentinal tubules and reach the pulpal tissues and cause pulpal diseases. So these are the few bacteria which are involved in dental caries. Now, what is the sequelae of pulpal disease? So if you see this slide, you can see that there is a normal pulp which, when exposed to certain kind of stimuli, can go into reversible pulpitis. Pulpitis, the word says it all. It is itis, inflammation of the pulp. So initially, it is reversible pulpitis. That means if your stimuli or your noxious agent is removed, the pulp will revert back to its normal healthy state. But if the noxious stimuli is not removed, then it progresses from there to irreversible pulpitis. That means the pulp has damaged irreversibly. The irreversible pulpitis can be of different kinds. It can lead to different reactions based on the bacteria, virulence, microorganism type, host resistance involved. So it can be chronic hyperplastic pulpitis, symptomatic irreversible pulpitis, asymptomatic irreversible pulpitis, or internal resorption. If any treatment is not done at this stage, then it proceeds to pulp necrosis. So this is Ingalls classification in which inflammatory changes and retrogressive changes have been described. This is Grossman's classification, which classifies diseases of pulp into reversible, irreversible, degenerative, and necrotic. Reversible pulpitis is basically mild to moderate inflammatory condition of the pulp, which is caused by noxious stimuli, in which the pulp is capable of returning to uninflammatory state following removal of the stimuli. So that means, let's suppose there is a caries which is going up to the dentine. Okay, So the pulp is in reversible inflamed state. Once you remove that caries process and restore the tooth back to its normal form and function, then the inflammatory state of the pulp returns back to normal, healthy state. The causative factors can be caries, recent dental treatment, defective restorations, exposed dentine, cervical abrasions. Symptoms, usually a short, sharp pain lasting for just a moment. The pain is very specific to the presence of stimulus. The moment the stimulus is removed, your pain goes back to normal. It is more often brought on by cold than by hot beverages and by cold air. On the radiograph, you may see normal periapical tissues or maybe a very slight widening of the PDL space. Treatment, removal of the noxious stimulus, prevention of caries, insertion of a filling if there is a cavity, and removal of the noxious agent is very important in this case. The second most common pathology encountered is your irreversible pulpitis. That is defined as persistent inflammatory condition of the pulp, symptomatic or asymptomatic in nature, with the pulp becoming incapable of healing. It's very clearly written that it is pulp cannot heal now. It's all irreversibly damaged. The types are asymptomatic irreversible pulpitis, symptomatic irreversible pulpitis. As the name suggests, asymptomatic, that means the patient has the condition but does not have any symptoms. And irreversible pulpitis means that the patient does not, patient has severe symptoms of pulpitis, that is inflammation. In the early stages, a paroxysm of pain may be caused by sudden temperature changes and pressure packing food into a cavity or suction exerted by the tongue or by the cheek. The pain may persist for several minutes to hours, lingering after removal of the thermal stimulus. So, this is very important that your pain is going to persist even after removal of your stimulus. Pain is sharp, shooting, piercing, and severe in nature. It may be continuous or may be intermittent. Patient may complain of postural pain also. So this is also very specific to irreversible pulpitis, that the pain is postural in nature. That means when the patient lies down, the pain increases in intensity. This is because of increase in the intrapulpal pressure. Patient may even have referred pain. That means the pain may refer to maybe ear or maybe to head or maybe to temporal area. In later stages, the pain may become more severe and is generally described as boring, gnawing, or throbbing kind of pain. Diagnosis, usually you will see a very deep cavity. On the looks of it, you are very confident that it is almost involving the pulp. Or you may see secondary caries under already restored tooth. Radiographically, you will see exposure of the pulp or caries under filling. Advanced cases may show you thickening of PDL or maybe some amount of periapical lesion also. So the treatment in such cases include simple endodontic treatment, that is root canal treatment. However, if your tooth is non-restorable, then you should consider extraction. Now, coming to the next one is your pulp necrosis. So, if the sequelae, if we go by the sequelae, it starts from reversible. If you do not intervene at that time, the disease progresses to irreversible. If you do not intervene at that time also, then again the disease progresses to pulp necrosis, wherein there is complete necrosis of the pulp. That means the pulp dies. So it may be partial or complete and may not involve all the canals in a multi-rooted teeth, especially in mandibular molars or maxillary molars. You may see that, the canal on the uninvolved side of the caries process may be vital, or you may find some vital tissue in the apical third of the root canal. So necrosis is of two types, coagulation and liquefaction. The types are pulp necrobiosis, pulp necrosis with no signs of infection, necrotic and infected pulp. In such cases, discoloration of the tooth is usually the first indication. So many a times, either the patient will come to you for a discolored tooth or it is diagnosed on a routine examination. So there will be no response to pulp sensibility test. That means on electric vitality test or pulp vitality test, you will not see any positive response. For first few months, there may not be any periapical changes, but in the later stage of the disease, there will be periapical radiolucency. The treatment, if the tooth is restorable, it goes to endodontic treatment. And if the tooth is non-restorable, then it goes to extraction. Now coming to the next entity that is called as chronic hyperplastic pulpitis. Here, again, the pulp is completely involved, okay? But the difference here is that, the patient resistance or the host resistance is very strong. So in highly patients with good immune system, you will see that there will be a low grade irritation which will lead to productive proliferation of the pulpal tissue. So this disorder is characterized by the development of granulation tissue covered at times with epithelium and resulting from long low grade irritation. Again, it's a symptomless situation. However, because there is proliferation of pulp in the entire cavity, there may be some discomfort on chewing or maybe some discomfort when the food gets packed into that cavity. Treatment is removal of this polyploid tissue followed by extirpation of the pulp. And if the tooth can be restored, you go ahead with root canal therapy. If the tooth cannot be restored, then you go ahead with your extraction. Coming to the next entity is internal resorption. Resorption, as the name suggests, resorption, something is getting resorbed over there. But now we just have to determine what is getting resorbed. So herein, dentine is getting resorbed. And it's the clastic cells which are causing its resorption. So resorption is defined as a condition associated with either a physiological process or a pathological process resulting in loss of dentine, cementum, or bone. So where do you see physiological resorption? You see that when resorption of deciduous teeth takes place. Internal resorption is an idiopathic, slow or fast progressive resorptive process occurring in the dentine of the pulp chamber or in the root canals of the teeth. So it is the resorptive process of the dentine. It gets replaced with the granulation tissue, and granulation tissue is very high in vascularity. So through the thin enamel, your underlying granulation tissue starts becoming visible, especially if your coronal dentine is being resorbed. And it gives an effect of pinkish hue to the crown. So that is why it is called as pink tooth of mummery. So internal resorption is also called as pink tooth of mummery. Treatment involves extirpation of the pulp, which will stop the resorptive process. You need to do routine endodontic treatment, but the only care you have to take is normal lateral condensation cannot be done in such cases because the resorptive area will be irregular in shape. So you need to use thermoplasticized cheapy to obturate such kind of cases. However, in many patients, the condition progresses unobserved and it is painless, so the root can get perforated. In such a case, surgical intervention along with MTA placement is required to repair the defect. Next one is your pulp degeneration. In pulp degeneration, there are different types. The first one is your calcific degeneration, wherein part of the pulp tissue is replaced by calcific material. That is your pulp stones and denticles. So herein, the entire pulp tissue can be replaced by calcified material. Atrophic degeneration is the atrophy of the pulpal tissue, wherein pulp tissue is less sensitive than the normal tissue. And fibrous degeneration, it is characterized by replacement of the cellular elements by fibrous connective tissue. Now, once the microorganisms progresses from coronal pulp to the radicular pulp, and then if you don't intervene at this stage, they progress beyond the pathology and the toxin products and the bacteria progresses beyond the apical foramen into the periradicular tissues, leading to periradicular pathologies. So coming to periradicular pathologies, if we see the sequelae, you see pulpal inflammation, which results in irreversible pulpitis. leading to pulpal necrosis. And if pulpal necrosis is not checked at this stage, it leads to periradicular diseases. Periradicular diseases starts from asymptomatic or symptomatic apical periodontitis. Asymptomatic apical periodontitis can further progress into asymptomatic chronic apical abscess or secondary symptomatic periodontitis or phoenix abscess, or maybe radicular cyst, which can be further classified into true cyst or base cyst or condensing osteitis. Symptomatic apical periodontitis may further progress into acute apical abscess and cellulitis. So all these things, if not checked in time, are going to keep on increasing in infection and multiplication of bacteria, and patient may be symptomatic, may not be symptomatic. The Grossman's classification is symptomatic periradicular diseases, in which we have symptomatic apical periodontitis, which could be there for vital tooth, non-vital tooth, acute alveolar abscess, acute exacerbation of asymptomatic apical periodontitis, which is also known as phoenix abscess. Asymptomatic periradicular diseases can be classified into asymptomatic apical periodontitis, chronic alveolar abscess, radicular cyst, condensing osteitis, external root resorption, persistent apical periodontitis, and diseases of the periradicular tissues of the non-endodontic origin. Ingalls classification classified into painful pulpo-periapical pathosis and non-painful pulpo-periapical pathosis. In painful pulpo-periapical pathosis, it can be classified as advanced apical periodontitis and advanced acute apical periodontitis, which can be further classified as acute apical abscess, phoenix abscess, suppurative apical periodontitis. Non-painful pulpo-periapical pathosis can be further classified into condensing osteitis, chronic apical periodontitis, chronic apical periodontitis, which can be further classified as incipient, advanced, periapical granuloma, apical cyst, and suppurative apical periodontitis. Coming to the first entity, it is known as symptomatic apical periodontitis. So whenever the word itis comes in front of any kind of organ, it simply indicates that there is inflammation of that particular tissue or organ. So now when we are talking about apical periodontium, apical periodontitis indicates that there is inflammation of the apical periodontal ligament. Now, it can be symptomatic or asymptomatic. Symptomatic, as the name suggests, that means there are symptoms present. How do you elicit whether apical periodontium is inflamed? So the only way to check this is that you elicit tenderness to percussion. If the patient gives you a positive response to tenderness to percussion, that means it is symptomatic apical periodontitis. If the patient does not give you any response to tenderness to percussion, then and you have PDL widening or some periapical pathology present, so that means it is asymptomatic apical periodontitis. Now, coming to the definition of this entity, it is defined as painful inflammation of the periodontium as a result of trauma, irritation, or infection through the root canal, regardless of whether the pulp is vital or non-vital, producing clinical symptoms including painful response to biting and percussion. History of previous pulpitis is usually there. So what are the etiology of this? Now, this is one entity in which the tooth can be vital or non-vital. So when do you see tenderness to percussion in vital teeth? So I keep telling everyone around me, all my students also, tenderness to percussion is not a test for pulp vitality. It is a test for inflammation of the apical PDL. So even in cases wherein the tooth is vital, at times you may find tenderness to percussion being positive. So what are the situations when the tooth is vital but still the tooth is tender to percussion? The first one is abnormal occlusal contact. Specifically, if you have a recent restoration in your mouth and the restoration has a high point. So after a day or two, patient will come back to you and there will be positive response to tenderness to percussion. That does not mean that you have to start an endodontic treatment immediately. That just means that you need to relieve that high point and maybe prescribe some anti-inflammatory drugs to the patient, and you evaluate the patient after a week and the patient will be completely fine. So abnormal occlusal contacts, recently inserted restoration extending beyond the occlusal plane, wedging of a foreign object between the teeth such as toothpick or food, traumatic blow to the teeth, all can lead to occlusal trauma, and this may give you positive response to percussion. However, one of the most common causes for positive response to percussion is the tooth being non-vital and the inflammatory components being extruded and being extended into the periapical tissues, causing periapical widening, periapical pathology, and leading to tenderness to percussion. So root, and also at times you will observe this that, when you started your endodontic therapy, at that time the patient's response to tenderness to percussion was not positive. But maybe on the second or on the third appointment, on the subsequent appointments, you will observe that the patient has positive response to the tenderness to percussion. What does that mean? That means that either you have done your instrumentation beyond the apex, or maybe you are irritants or irrigants have gone beyond the apex and have irritated the periapical tissues. Or maybe if you observe tenderness to percussion after your obturation, then in that case, maybe your obturating material, sealer or guttaperca has gone beyond the apex into the periradicular tissues. So these are the iatrogenic causes of symptomatic apical periodontitis. Clinical features are pain and tenderness of the tooth. Sometimes when it is percussed in certain direction, you will feel that the tooth is sore. The tooth may feel extruded and the patient may have pain on closure or mastication. The tooth may be slightly elevated in its socket, especially if there is inflammatory edema in the PTL space, or it may cause tenderness while biting or even on touching. Thermal changes do not induce pain as in case of pulpitis. External pressure on the tooth may force the edema fluid against sensitized nerve endings and result in severe pain. So in case of, if you take an RVG or a X-ray of such a tooth, so if the tooth is vital, you may not see any radiographic changes. However, if the tooth is non-vital, then you may see widening of the apical periodontal ligament and loss of apical lamina dura of the involved tooth. So diagnosis is basically by visual. You're going to look for any signs of decay, fracture line, swelling, sinus tract, hyperocclusion, tenderness on percussion, tenderness on palpation to be observed, mobility to be checked, and vitality testing is very important to determine whether your pulp is vital or non-vital, because based on the vitality test, your treatment will change. So if it is a vital tooth, then in that case, you just determine the cause why the patient has positive response to tenderness, and you eliminate the cause and the tooth will be fine. The patient will be fine. However, if it's a non-vital tooth, then you proceed with your endodontic therapy and prognosis is generally favorable. In case you cannot save the tooth, you cannot restore the tooth, then you have to consider extraction as your choice. Now coming to the next entity, that is your asymptomatic apical periodontitis. It is defined as inflammation and destruction of apical periodontium that is of pulpal origin, and it appears as an apical radiolucent area and does not produce any clinical symptoms. So the tooth has become non-vital, but the patient is asymptomatic, and it has remained non-vital for quite a period of time. Patient is totally asymptomatic, but when you take a radiograph, you see a periapical radiolucency. So it's basically a chronic low-grade reaction of the alveolar bone to the irritation from the root canal. Clinical features, the tooth is non-vital. There may be very slight tenderness to percussion, but usually it is not. Mild pain on biting or chewing may be there or may not be there. The tooth may feel slightly elongated in the socket. Sensitivity due to hyperemia, edema, and inflammation of apical PDL may be observed. Many cases are, however, completely asymptomatic, and there is no sinus tract formation or nothing seen over there. Radiographically, you will see thickening of the ligament at the root apex, and maybe you will see a radiolucent area of variable size. So periapical radiolucencies indicate the bone destruction and replacement of that area with granulation tissue. Treatment. So if the tooth can be saved, we go ahead with endodontic therapy. If the tooth cannot be saved, then extraction. With the endodontic therapy, at times you may have to give some non-steroidal anti-inflammatory drugs. So, however, antibiotics is not recommended unless and until you have some systemic involvement for the infection. Now coming to the next one, that is your acute alveolar abscess, an inflammatory reaction to the pulpal infection and necrosis characterized by rapid onset, spontaneous pain, swelling of the tooth to pressure, pus formation, and eventually swelling of the associated tissues. So there are a lot of synonyms to it. Basically, it is periapical, acute periapical abscess. That means the granulation tissue has been there. There is pus over there, and this will lead to resorption of the bone from that area and a soft tissue swelling. So etiology is usually bacterial invasion of the dead pulp tissue. You can see it in trauma cases as well. Because the pulp tissue is solidly enclosed, no drainage is possible. The infection continues to extend in the direction of least resistance, that is through the apical foramen into the PDL and then into the periradicular bone. So it is symptomatic. Usually you will see some purulent material within the alveolus. Tenderness is there. Then slight pressure on the extruded tooth will cause relief of pain. Spontaneous severe throbbing pain, which exacerbates on lying down. Swelling is pronounced and it extends beyond the original site. Usually the swelling can be intraoral and it may extend even extraorally. Okay. If left unattended, it at times, patient may not come to you immediately. And after some time, there's a slight puncture over there, or there's a sinus tract formation and the pus drains, and the patient does not report back. It may further progress to osteitis or cellulitis or osteomyelitis and may involve the adjacent tissues as well. Radiographically, since it's an acute reaction, you may not see such an evidence of periradicular bone destruction. But if in case this is an exacerbation of a previously existing chronic condition, then you will see a huge periapical lesion. Okay. Treatment, again, if the tooth is restorable, we do endodontic treatment. If the tooth is non-restorable, then we do extraction. So if you're planning for an endodontic treatment, you have to ensure that through your access opening, the pus should drain out. If in case the pus does not drain out through your root canal after your access opening and initial biomechanical preparation, then you should plan for incision and drainage of the soft tissue. So root canal treatment or extraction to remove the source of infection. You may need antibiotic therapy in such cases because there is some kind of systemic involvement, and if required, surgical intervention will be appreciated. So if you see this case, you can see that there is a huge facial swelling on the right side of the patient. This is pre-operative. After the treatment was initiated, you can see the reduction in the swelling. After the completion of the treatment, the swelling is completely gone and the patient's facial appearance has returned back to normal. And this is the follow-up at 16 months. Correspondingly, you can appreciate the radiographic appearance. This is preoperatively. You see a large carious lesion involving the pulp chamber, and you see a small periapical lesion which is present over there. Immediate post-operative, you see 4 canals obturated and a good coronal restoration. However, there is a periapical lesion, but when you follow it up, now you see there is complete resolution. Although my coronal restoration has dislodged, but you see a complete resolution of the periapical lesion on the mesial root, as well as no further leakage is present, so you cannot see anything on the distal root. Now coming to acute exacerbation of asymptomatic apical periodontitis. This is also known as phoenix abscess. So as the name is suggesting, phoenix is something which is going to be dead and then rise again. So chronic apical abscess. So abscess is accumulation of pus. So when there is accumulation of pus in chronically, for a chronic period of time, for a long period of time, at times, after some time, it becomes acute and active, and patient may have symptoms. So patient may have been asymptomatic for quite some time, and then suddenly one day there is a flare-up, and patient may come to you with symptoms of acute apical abscess. So this condition, wherein in a chronic apical abscess, you observe symptoms of acute apical abscess, is known as acute exacerbation of asymptomatic apical periodontitis. Okay. So usually it happens when there is the state of equilibrium in granuloma or a cyst is upset by influx of bacteria or necrotic products of high virulence and antigenicity, or lowering of host defenses. Or at times, because it can come as a flare-up once you start your endodontic therapy. Coming to the clinical features are more or less same as your acute apical abscess. Exacerbated and exaggerated pain may not be associated with pus and suppuration. Initially, tooth may be tender on palpation. Loss of vitality. As the inflammation progresses, the tooth gets elevated from the socket and is sensitive. Mucosa over the radicular area may appear red and swollen and sensitive to palpation. Many a times it is associated with initiation of root canal therapy. Now that leads to a question: why after starting the root canal therapy you will observe phoenix abscess or a flare-up? That is because when most of the times when you're doing endodontic therapy, it is because of the bacterial involvement of the pulp space, pulp tissues and periradicular tissues. So there are good amount of bacteria or microorganisms present inside the root canal system. So when you start your endodontic therapy, you are disturbing the equilibrium which is present inside the root canal space. So in reaction to your action, the bacteria or the microorganism proliferate very rapidly, to the extent that the host response is inadequate to counter them. And it goes for a flare-up or a phoenix abscess. Mobility may also be observed. Diagnosis is initiation of root canal therapy in a completely asymptomatic tooth. The radiograph shows a well-defined radiolucency. History of trauma, negative response to vitality tests. Treatment is same as acute alveolar abscess, and the prognosis for the tooth is good once the symptoms have subsided. Now coming to chronic apical abscess. As the name suggests, chronic. It indicates the periodicity of the disease duration. That means the disease has been present for a long period of time. So it is an inflammatory reaction to pulpal infection and necrosis characterized by gradual onset, little or no discomfort, and the intermittent discharge of pus through an associated sinus tract. So there has been pus formation and there has been a sinus tract formation along with it. And the pus keeps on getting out from the sinus tract. So there is no acute phase happening over here. So symptoms are generally asymptomatic or maybe very mildly painful. Presence of sinus tract is the only indication, and you may see it on a routine a routine clinical examination. Sinus tract usually prevents the exacerbation or swelling by providing intermittent drainage of the periradicular lesion. Here in these case, you can even see a extraoral sinus. In few cases, you can observe even extraoral sinus present. And you can do sinus tracing to determine the exact offending tooth to be identified. So how do you do a sinus tracing is that you take a 35 or 40 size Gataparka cone and you insert it through the sinus to the area of maximum resistance, and then you take a radiograph. Usually the sinus will go to the lesion wherein your offending tooth is present. Okay. So radiographic findings are very similar to the asymptomatic apical periodontitis. However, borders of the radiolucent lesion may not be so well defined. Treatment again is endodontic therapy in case the tooth is salvageable. In case the tooth is non-salvageable, then you go ahead with extraction. Now coming to condensing osteitis. Till now we have been discussing cases wherein or entities wherein there is radiolucent lesion. Now we are going to talk about the radio-opaque lesion. There is formation of bone, okay, like not reactive bone formation because of low-grade irritation. Again, it's just that the body reaction is slightly different in this case. Instead of bone resorption, there is bone deposition which is happening over here. Diffuse radiopaque lesion usually surrounding the root apex and characterized by a localized reaction of the bone to low-grade inflammatory stimuli egressing from the root canal. It is more often seen in mandibular molars with pulp necrosis or asymptomatic pulpitis. So you can see here reactive bone formation around the periapex of the endodontically involved teeth. Clinical features, usually young patients, mandibular first molar, grossly carious, can be vital or non-vital, asymptomatic usually, and you see a radiopaque mass associated at the apex of the endodontically involved tooth, and lamina dura, if you observe, is intact in such cases. Treatment, removal of the irritant, endodontic treatment in case there is signs and symptoms of irreversible pulpitis. Long-term retention, if the tooth is restorable and a good endodontic treatment can be done, the prognosis is very good. However, in such cases, the lesion may persist even after endodontic treatment. Now coming to the next one, that is your periapical cyst or root end cyst. So now when you're talking about cyst, it is very understandable that it is like a sac wherein there is a cavity inside the bone which is lined by a epithelium. So that is a cyst. So epithelium lined cavity or sac at the apex of the tooth is called as radicular cyst or periapical cyst. So it is usually a sequel of the periapical granuloma or asymptomatic apical periodontitis. The epithelial lining is derived from the epithelial cell rest of molasses. Now, there are 2-3 theories which have been put forward as a possible cause for the development of the cyst. One of them is your nutrition deficient theory, and another one is your abscess theory. Now, coming to the types of cyst, there are 2 types of cyst. First one is your periapical pocket cyst, and the second one is periapical true cyst. So the periapical pocket cyst is also called as base cyst or false cyst. What has happened here is it is the epithelium lining, okay, is in continuation with the periapical area of the tooth, periapex of the tooth. So basically the cyst is communicating with the root canal space. Okay, so this is a periapical pocket cyst. In such cases, most of the time, this cyst resolves upon successful endodontic therapy. Periapical true cyst, wherein it is a true cyst wherein your epithelium lining is complete and it has no communication with the root canal. So clinical features are usually asymptomatic. If you see on a radiograph, when you compare it with the periapical granuloma, the size of the lesion is usually larger. generally more than a centimeter, you can see a thin radiopaque line surrounding the radiolucent lesion. It is not a very confirmatory finding, but usually you see this. Nowadays, we have CBCT, and on the CBCT, you can actually visualize the cystic lining also and have a confirmatory diagnosis whether it is a periapical granuloma or a lesion or a cyst. It develops over a long period of time, acute exacerbation, then abscess, and acute exacerbation can lead to formation of abscess and then cellulitis. It is identical in most cases with that of periapical granuloma, but usually cyst is slightly bigger in size in granuloma because it is present from a longer duration of time. Occasionally, a thin radiopaque line around the periphery of the radiolucent area may also be seen. The tooth is non-vital. There can be some history of pain or trauma in the past. Radiographic diagnosis is loss of continuity of the lamina dura. Radiolucent area is generally round in outline and may involve the adjacent teeth also, and may involve more than one teeth. Treatment: 80 to 98% of the radicular cysts undergo resolution after root canal treatment and do not require any form of surgery. However, for such a patient, you always recall the patient on a 3-month follow-up period. And if you feel after 2 years that that your lesion has not reduced in size at all, and there have been persistent symptoms, then you may consider endodontic surgery for the patient. Now coming to the next entity, that is your external root resorption. That is basically the lytic process, that is resorptive process occurring in the cementum and dentine of the roots of the teeth. So we have 3 types: external surface resorption, external inflammatory root resorption, and external replacement resorption or ankylosis. So you see radiolucent concave bowl-shaped excavations along the root surface. Complete loss of lamina dura is seen. Initial signs can be seen as early as 3 to 4 weeks. Area of replacement resorption or ankylosis, you see resorbed root without any periodontal ligament space and bone replacing the defects. So you may see a moth-eaten radiolucent appearance in case of external surface resorption, or you may see root being blended with bone in case of ankylosis or replacement resorption. So the tooth in question may look to normal, vitality is negative, and in advanced cases, you may see discolored tooth, sinus, tenderness to percussion, and palpation. External resorption, you will see blunting of the apex and scooped out areas on the sides of the tooth. Internal resorption is this wherein there is ballooning of the canal space. So you need to differentiate from external root resorption, which can be done easily with multiple angulated radiographs. You need to remove the cause, you need to do root canal, you need to replace and use probably MTA on those areas. You may end up doing some kind of surgical therapy also. Now coming to the last entity for the session, that is post-treatment apical periodontitis, as the name suggests, post-treatment. So you have done the endodontic therapy, but still there is persistent apical periodontitis present over there. So it can be classified as 3 types: emergent, that is if it develops after treatment; persistent, if it persists even after having treatment; and recurrent, if the tooth has healed and then it develops later. So usually it is observed wherein endodontic treatments have not followed the standard protocol. 5 to 15% is the incidence in such cases. How do you manage? If it is symptomatic and you see inadequate root canal treatment and there is coronal access is available, you do a retreatment. In case where you feel that retreatment is not feasible, then you probably may consider surgery as a better option. These are the lesions of periradicular lesions of non-odontogenic regions such as odontogenic cysts, bone pathologies, odontogenic tumors, and non-odontogenic granulomas and cysts, wherein you have lesions, but they are non-odontogenic, non-tooth related factors. So with this, I conclude my presentation. I hope what we have discussed will help you understand the pulpal and periapical pathologies, and you can make a good diagnosis and a good treatment plan for your patients. Thank you.